Good evening to everyone, and thank you very much for joining us for the Practice Standards and Clinical Documentation webinar and everyone online here tonight. My name is Melissa Malberg, and I am a registered dental hygienist and one of the practice advisors with the college.
And my name is Jacqueline Guyader. I'm also a dental hygienist and a senior practice advisor with the college. We're here this evening to run through some simple practice scenarios related to the practice standards, with a focus on documentation. This interactive session will give you the opportunity to assess your practical knowledge of the CDHPC practice standards. Our goal is that through these questions and scenarios, you will be able to take away information that can be applied to your practice setting. We anticipate the session to take approximately an hour with a time for question and answers at the end of the session. However, at any time during this session, you can log in your questions, but again, we'll only be answering them at the end of the session.
All right. So as professionals, reviewing the practice standards and reflecting on our practice in the context of those standards is something that we should all be doing on a regular basis in order to ensure that we are providing our clients with safe and quality dental hygiene care. So in order to help with this, we've developed a session in which we are going to review the practice standards related to chart documentation and the required criteria. We'll talk about the importance of adequate chart documentation as well as potential pitfalls to avoid. We'll talk about some chart documentation omissions along with examples, and we'll discuss some practical ways that we can incorporate these documentation standards into the clinical setting. So to start off, we're going to review the CDHPC practice standards just at a very high level of what each of them entail. So the first practice standard deals with informed consent, which of course needs to be obtained before beginning dental hygiene treatment. And this is defined as the client having the right to accept or decline treatment that once they have understood the risks, benefits, and costs associated with the different treatment options. The second practice standard deals with provisions for safe care. And this includes using recognized infection control protocols, as well as ensuring client protection and using, such as the use of safety glasses. The third practice standard requires that a dental hygienist must assess the client's needs at the outset of care and then update as appropriate using their professional judgment. And this includes a review of the client's chief complaint or concern. The fourth practice standard requires that a dental hygienist use that assessment information in order to determine a dental hygiene diagnosis. And this may include short and long-term prognoses, as well that this dental hygiene diagnosis and along with any implications associated are discussed with the client.
The fifth practice standard requires that a dental hygienist must plan for the dental hygiene care that is going to be provided. This is based on the assessment information and the dental hygiene diagnosis, as well as consulting with other healthcare professionals as needed. The plan for services and any recommendation referrals must be discussed with the client. The sixth practice standard that a dental hygienist has to complete is the implementation of the plan, but it needs to be consented to by the client. As well, if there's any changes required to the plan, the client must agree to these as well. Practice Standard 7 addresses the evaluation phase of care, both during and upon completion of care, in order to determine if the desired outcomes have been achieved. This practice standard also deals with discussing follow-up care recommendations or any referrals to any other healthcare providers, such as a dentist, a physician, or a nutritionist. And the final practice standard, number 8, outlines documentation requirements that were established by the college. It's important for all registrants to be familiar with all 8 practice standards and to ensure that they are applying them to their practice setting. For further information, the practice standards can be found at the CDHPC website.
So the CDHBC expects that dental hygienists ensure the safety of clients at all times and that the ADPI dental hygiene process of care is followed, which we all know stands for assessment, diagnosis, planning, implementation, and evaluation, and that this process of care is appropriately documented.
Why is appropriate chart documentation so important? Well, the chart truly is a legal document that should accurately and adequately reflect the client's general and oral health, as well as the services that were provided. Accurate and chronological records that effectively outline the ADPI process of care help practitioners provide comprehensive care and ensure continuity when aspects of care are shared between practitioners. As a legal document, the chart record carries implications for financial aspects of care, including fees for services. Accurate documentation of oral characteristics may be of assistance in the event of a tragedy. And lastly, the dental chart is a legal document and often the first line of defense in an inquiry or complaint. The college has seen an increasing trend in inquiry complaints, both in the number and complexity. Accurate and adequate records really are a practitioner's best defense in the event that a complaint is ever made to the college, as well if you are ever questioned by an insurance company in regards to billing. As the familiar saying goes, if an aspect of care was not documented, it can be assumed not to have occurred. This is a good time to mention that dental hygienists who own their own practice are responsible for maintaining documentation, but as well they're responsible to ensure that those records are stored in a secure and confidential manner. With the rise of inquiry cases coming to the college, there has been an increasing trend in the following documentation errors or omissions: the failure to document health history or the health history update, the failure to document the dental hygiene diagnosis, a failure to document the dental hygiene treatment plan, failure to document informed consent or refusal, failure to document the 365-day exam, entries that are not of adequate detail, and omission of the operator initial at the end of the entry.
So we are going to be presenting some examples related to the college's practice standards and documentation requirements, and some of which will include a clinical scenario. We're going to ask a question and then we're going to open the polling software in order to gather everyone's answers. You'll hear a little 10-second clip of music while the polls are open, and the question is going to appear on your screen in the lower left-hand corner where it says poll area. So once the question comes up, the answers will be written down as well, and there'll be a little radio button in front of each answer. Please select that radio button in order to vote for that particular choice. And if you do choose the wrong one or wish to switch your answer, you're free to do so as long as that music is still playing and the poll is still open. The computer will remember whatever the last selection is that you make. So after the music does end and the polls are closed, we'll be able to display the results on the screen to see what everyone thought. And please know your answers are anonymous, so please be honest when making your choices. All right, we're going to start off with a warm-up question here, just to make sure everyone is comfortable with logging in their vote. So the question reads, the transmission of the Ebola virus is through direct contact with blood or body fluids and is not spread through the air. Is this true or false? I'll open the polls now and you can log in your vote. All right, the polls are closed there. So the correct answer here is true. It is not spread through the air and only through blood or body fluids. So let's move on to the next question. This is another warm-up, but this one's a slightly different format. This is going to be a multiple choice answer. So there's going to be selection 1, 2, 3, and 4 on your screen. So this question says, which eligible bachelor in Hollywood was recently taken off the market? Was it Orlando Bloom, George Clooney, Tom Cruise, or Leonardo DiCaprio? And again, I'll open the polls. All right, polls are closed here. I can see everyone has been updating themselves in the gossip magazines in the reception area because the correct answer here is 2, George Clooney. So I hope everyone feels comfortable with the voting, and we're going to move on to the presentation questions now. So the first question, all client records must be labeled with the client's name and date. Now, is this true or false? And again, I'll open the polls now. All right, polls are closed, and 97% said the correct answer was true, and that is right. So Practice Standard 8 does require that the dental hygienist document the client's name and the date on all client records, and that includes radiographs and other forms or study models that may not be a part of the actual physical chart.
Our next question is, which of the following is correct regarding documentation requirements in the client treatment record? Is it 1, entries should outline the ADPI process of care that took place in a given appointment? 2, entries made in pencil can be erased provided that the correct entry is completed at the same time? 3, entries made in ink can be corrected with whiteout? Or 4, entries in the treatment notes must include the client's insurance coverage information? I'll open the polls now. And the correct answer is 1. Practice Standard 8 specifies the requirement to accurately record details of the dental hygiene care provided following the ADPI process of care for each appointment. Options 2 and 3 are incorrect, as Practice Standard 8 requires that entries in paper charts be non-erasable, in ink, and that the original entry is still visible once the correction is made, and that the corrections be initialed by the dental hygienist. Option 4 is incorrect, as there is no requirement in the practice standard that insurance coverage information be documented in the treatment notes. In fact, financial information is best housed in the accounting portion of the chart.
All right, on to question number 3. Based on the CDHBC practice standards, which of the following would be considered an omission or error in a client's treatment record? 1, failure to record periodontal assessment data and a dental hygiene diagnosis. 2, failure to document a dental hygiene care plan. 3, failure to document informed consent. Or 4, all of the above. I'll open the polls now. Please vote. Excellent. So the correct answer here is number 4. So the CDHBC practice standards stipulate that periodontal assessment data, the dental hygiene care plan, and informed consent all need to be completed and documented in a client's treatment record. And I'm sure for most of you this probably seemed like an easy question, but it's actually an example of the type of scenarios that are seen in complaints that are reviewed by the inquiry committee. For example, there was a case recently reviewed by the committee where a complaint was made against a dental hygienist from a client, and as part of the investigation, the dental hygienist submitted this client's chart documentation. And apart from any financial information and the medical history information that were in other areas of the chart, the following was the full chart documentation completed by the dental hygienist. So you can see here that there was a new patient exam completed, Dr. X, 2 units of scaling, a unit of root planing, health history update was done, intraoral, extraoral exam was completed. There are notes regarding the amount of plaque and bleeding, that the client seemed unhappy, that hand scaling was used, and that the client left without oral hygiene instruction or a toothbrush. So please note that all names and references that we are using throughout this presentation have been changed and are fictional, so that everything is completely anonymous. But what you can see from this case is that there are significant elements of the process of care that were not documented. And you can see the chart did not include any documentation of informed consent. There was no information on care planning, either for that initial appointment or for any follow-up appointments. And lastly, and perhaps most significantly, the chart did not include any periodontal assessment data apart from the note about existence of some recession. Now, this makes it very challenging to establish a dental hygiene diagnosis and a proper plan for treatment. And it also leads the client, and possibly the practitioner, being unaware of what their periodontal status is, and therefore they're unable to provide informed consent for the different treatment options.
So I'm going to take us to our first practice scenario, followed by a question related to this scenario. So we have Kelly, who's a dental hygienist. She's working on a periodontally involved client. At the initial appointment, the assessment phase was completed, a dental hygiene diagnosis, and a plan for a series of quadrant debridement was planned. This was discussed with the client, who provided informed consent. Today, the client is in for their third debridement appointment in quadrant 4. I'm going to pull up a slide that will show you how Kelly documented today's appointment. So we can see that Kelly's entry looks like this. She notated that the health history and dental history were updated. She documented the client's chief complaint. She included the blood pressure reading at this appointment. There's a notation about the pre-procedural rinsing agent, as well as the use of local anesthetic, the drug that was used, the area that was anesthetized, and the volume. Kelly has also included notations about the tissue response in quadrant 2, which was previously debrided at the last appointment. And there's also notes that are documenting the treatment area for today's appointment. And then finally, there's notes about the OHI that was provided at today's appointment. So the question related to this scenario is, based on the CDHBC practice standards and this scenario, which of the following is an omission or error in the client's treatment record? Is it 1, incorrect documentation of pre-procedural rinse, 2, failure to address the chief complaint, 3, the RDH initial missing at the end of the entry, or 4, incorrect documentation for pain management? I'll open the polls now. Okay, the correct answer is 3. The dental hygiene initial is missing at the end of the entry. Although this can seem like a relatively small omission, it does have legal implications, as the dental hygiene initial can provide other operators with a clue as to who provided that care, and it can determine who is responsible for the aspects of that care. For that reason, Practice Standard 8 requires that all entries, as well as corrections or changes, be initialed or signed in the chart by the hygienist. This also is a requirement for electronic charts as well, but we'll take a look at that in just a moment. Options 1, 2, and 4 are incorrect, as all of these were documented appropriately in the client treatment record. Now let's go back to the electronic records. It's worth noting that once entries are made in a computerized chart, they also become a part of the permanent dental record, and they should not be deleted. In keeping with the principle that corrections made in paper charts must maintain the visibility of the original entry, the same applies to electronic charts. If a correction needs to be made, it should be documented as a late entry or an addendum, followed by an explanation of the correct information along with the practitioner's name or initial and the date that the correction was made. The use of font strike-through can be a useful tool as it maintains the visibility of the original entry, and then you can follow that with the correct entry that was required, followed again by the initial. It's worth mentioning that challenges have come up with evidence from electronic charts in the context of inquiry complaints. There have been cases where it's been difficult to determine who made certain entries in the charts. For this reason, the use of individual staff logins and passwords are highly recommended for computerized offices, so that an audit trail of the documentation in the client's chart and which staff members have made those entries can be maintained or determined. I'm sure many of you work in offices that have gone to electronic charts. You might be interested to know that the College of Dental Surgeons requires individual staff logins and passwords.
All right, let's move on to our next scenario. Here we have Maggie, the dental hygienist, who is seeing Mr. Jones, and he's a new client to the practice. Mr. Jones was seen last week by the dentist for a new patient exam, and that included taking the medical and dental history, completing dental and occlusal assessments, as well as taking radiographs, all of which were discussed with him. Now, Mr. Jones is 58 years old, he smokes a pack a day, and is on medication for high blood pressure. Today, Maggie has her first dental hygiene appointment with Mr. Jones, and he tells her just how much he loves coming to the practice. He feels so comfortable, everyone makes him feel at home. So during the appointment today, Maggie documents any updates in the medical and dental history and includes Mr. Jones's oral hygiene routines. She completes and documents assessments of deposits, the gingival condition, as well as the periodontal status, including full mouth probing, recession, furcations, and mobilities. She also completes debridement in the second and third quadrant and documents this appropriately. She then includes notations about oral hygiene instruction given regarding fluoride use, as well as the modified Bass brushing technique. So the question reads, what required assessment information was not obtained and documented by Maggie during this appointment? Was it 1, checking the client's anxiety level, 2, baseline blood pressure and EOIO assessments, 3, counseling related to smoking cessation, 4, discussion of the radiographic findings? And we'll open the poll now. All right, so the correct answer here is number 2. Baseline blood pressure and the intraoral, extraoral assessments were not completed on this client prior to the implementation of dental hygiene care. So Practice Standard 3 does require that baseline assessment data be collected by dental hygienists for all new patients, or supplement data that was collected by another health professional, such was the case in this scenario, where the dental occlusal assessments as well as the radiographs were all completed and documented by the client's attending dentist. So while the extent of the baseline data collected does vary between practice settings as well as individual clients, in the scenario we described, the client does present with specific health risks related to his smoking status and being on high blood pressure medication. So therefore, the omission of the baseline blood pressure as well as the intraoral, extraoral assessments are really critical points that were missed. So answer 1 is not correct, as the client had indicated how relaxed he was in the environment and really enjoyed coming to the practice. Answer 3 is not correct because this is part of the implementation phase of care, not the assessment, like the question was asking. And answer 4 is not correct, as this would be part of the discussion during the presentation of the dental hygiene diagnosis and care plan.
So our next question is, a client showing up for an initial dental hygiene appointment meets CDHBC Practice Standard 1 for informed consent. So here's the scenario. You have a new client who's shown up to your office for their dental hygiene appointment today. They've come to the office, they've checked in with the receptionist, who's had them complete all the appropriate paperwork, and then they're seated in your chair. The statement is saying the act of this client showing up for this appointment meets Practice Standard 1 for informed consent. Is this true or false? I'll open the polls. And the answer to this is 2, false. The act of the client showing up for this first appointment and sitting in the dental hygienist's chair is an example of implied consent. However, at this point, the nature of the treatment has not yet been determined as assessments haven't been completed. As well, risks or benefits about any proposed treatments have not been explained to the client. Therefore, in this scenario, implied consent is not sufficient to comply with Practice Standard 1. We get questions at the college periodically about informed consent protocol. Our recommendation is that best practice is to have the client sign in the chart that they understood the care plan that was presented to them. However, a dental hygienist can also document in the chart that verbal informed consent was obtained. Both of these 2 examples will satisfy Practice Standard 1 for informed consent. Here's another scenario. After obtaining consent from the client Jane, Michael, the dental hygienist, takes 4 vertical bite wings. This is occurring during the assessment portion of care. Once Michael has processed the radiographs, he uses them to assist in the development of the dental hygiene diagnosis. So based on this scenario, which of the following is not a CDHBC practice standard requirement? Draping the client with a lead apron and thyroid collar during exposure to x-rays. 2, discussing the radiograph findings with the client. 3, documenting the exposures that were taken, for example, 1 PA or 4 bite wings, as well as documenting the findings in the treatment record. Or 4, ensuring that the bite wings are on the view box during debridement. I'll open the polling. Okay, the answer to this is 4. Although it would be considered best practice to have the bite wings on the view box, it's not a practice standard, whereas options 1, 2, and 3 all require practice standards. In regards to answer 1, Practice Standard 2 requires that the dental hygienist must protect the client during the exposure of radiographs with a lead apron with a thyroid shield. Regards to answer number 2, Practice Standard 4 requires that a dental hygienist must analyze and interpret assessment information and share these findings with the client. Lastly, regarding answer 3, Practice Standard 8 outlines the need to accurately record details of the dental hygiene care provided, which would include the exposure of the radiographs and the subsequent interpretation of the dental hygiene findings.
All right, on to our next scenario. Here we have Lindsay, who's the first client of the day for dental hygienist John. She's 3 months overdue for her 6-month dental hygiene appointment. And during the assessments, John notes that more debridement is going to be required, and as luck would have it, the next patient of the day canceled. So John keeps Lindsay for a total of an hour and a half in order to complete the dental hygiene care instead of just the 1 hour that was originally booked. So the question here is asking, according to the CDHBC practice standards, it is not a requirement to document in the client's record the amount of time John spent providing dental hygiene care for this client. Is this true or false? And we'll open the polls. All right, polls are closed. The correct answer here is 2, false. Practice Standard 8 states that when appropriate, the dental hygienist should document the amount of time spent with the client. So in this scenario, the dental hygienist normally has a 1 hour time period for an appointment, but since the second person of the day canceled and John ended up spending an hour and a half with the client, this needs to be documented as an audit trail. Otherwise, it would look as though more services than could realistically be provided in that time frame were actually billed. Now, this is another area that comes from examples that we see in the inquiry cases, because the committee has received complaints where clients have alleged they were billed for more than the actual time that was spent with them. So once again, document in the treatment notes instances where the client's appointment has differed from what was originally scheduled, and even just making a short notation that the client came late or had to leave early, and just how that appointment time varied from what was scheduled.
So in this next question, we do have an excerpt from the chart. The dental hygienist wrote that the dental hygiene diagnosis was discussed with the client. That diagnosis was generalized mild plaque-induced gingivitis with localized moderate chronic periodontitis in the quad 2 molars, as well as a moderate caries risk. This following information meets the CDHBC practice standards regarding the dental hygiene diagnosis. Is this true or false? I'll open the polling. And the correct answer is 1, true. The information documented here outlines statements identifying concerns related to the client's oral health and interprets the assessment data. The dental hygiene diagnosis then ties all the analyzed assessment information to the planned interventions. As we've mentioned, the implications of the assessment findings and the dental hygiene diagnosis must be discussed with the client. This would include identifying conditions that are abnormal or unhealthy, such as periodontal disease, caries risk, xerostomia, or special care that might require a referral. Not all dental hygiene statements are going to look exactly the same, as some may be documented in the form of a description of the assessment findings. The important component here is that there is some kind of documentation in the chart outlining that the assessment data was interpreted and then analyzed, interpreted, and then discussed with the client.
All right, so that wraps up the interactive voting portion of our session, but we just have a couple more slides left. I'm going to recap some of the practice standard policies that are specifically related to documentation. So this includes the requirement that all client records be labeled with the client's name and date, that requirement that accurate details of the dental hygiene care provided are recorded, and that's based on the ADPI process of care, as well that notes are made about the services that were provided. For example, pain control methods, home care precautions, or other instructions that were given. Next is the requirement that entries are made in a legible, objective, permanent, and secure manner, and that entries and corrections include the dental hygienist's initials or signature. They should also be documented in chronological order following the ADPI process of care, and this of course applies to electronic records like we discussed. The next point is that details of pertinent client discussions, as well as consultation notes with other practitioners, are kept in the client's chart. And lastly, the requirement that instances of informed refusal to consent are also recorded and initialed by the dental hygienist. As an aside, if there is ever some sort of misunderstanding about the nature of a declined or refused portion of care, these entries really become a practitioner's best defense in the event that a complaint is made down the road. And we often informally recommend just having that client initial or sign that entry in the chart as well, just as confirmation of their informed refusal. Next, we're going to move on to some practical applications. So these are ways that, or some examples that you can take from today in order to apply all of these standards into your clinical practice. So first of all, template chart forms are a great way to save time as well as prompt that ADPI process of care that we've been consistently talking about in your documentation. Oftentimes using tick boxes or circle options throughout these forms are a really quick and easy way to complete the documentation and make sure that you are recording all aspects of care. For example, having a box written out with 0.12% chlorhexidine pre-rinse for 1 minute, and you can simply circle or tick that option instead of writing out the full entry. You can also do that with common dental hygiene diagnoses. You can list gingivitis, periodontitis, the mild, moderate, and severe, and you can circle those options and then make additional notes as related to that specific client and their individual condition. Another great idea is with informed consent. As we just talked about, this is something that's really often missed. So having a box on your chart that says verbal informed consent obtained from patient and a tick box, it's documented. So abbreviations are also another great way to help with keeping documentation quick and making sure that everything is incorporated, but it's also important to make sure that everyone in your office is on the same page. So having an office policy manual where you stipulate exactly what each abbreviation means, that can really help everyone be on the same page and not get confused in regards to different abbreviations. Also, many of the new computerized charting systems can save time as well because they have template forms that are embedded within. So you're simply clicking on different selections versus actually typing or writing it all out, which again can save time. Overall, just really working with a systematic approach because this reduces the risk of missed information and really allows you to get in the habit of consistent chart documentation. All right, so I want to thank everyone so much for their participation tonight. We do have a short period of time now for any questions that are related to documentation. And please know if we don't get to your questions, you feel free to give us a call or email us at the college, and we will be very happy to help you out. So I believe Jackie is going to come in and we will go through some of the questions. And again, feel free to keep entering them in the question box as we go through here.
So I do have a couple of questions here, Melissa. The first question that we have, a registrant is asking, how long are we legally required to keep the charts? This is a great question. Based on the Limitations Act, it is a requirement that charts are kept for 15 plus 1 year. So we do have a requirement to keep those charts in a secure and confidential manner for 16 years. However, if the chart is related to a minor who's in your care, there is a requirement to keep those charts for 16 years after the age that that client turns 19. So the time frame can be a little bit longer on that one. And the next question we have is it okay to have the schedule adjusted as well? So I hope that I'm interpreting this question correctly. And I'm thinking that means the time. So if your time was extended to that hour and a half because the next client canceled, it is okay to have the schedule adjusted. However, you should make notations in your chart as the chart is the legal documentation, and that would be something that if there is an investigation that is required would be looked at. Because sometimes if it's not a computerized office, not all day sheets are always maintained. However, keeping both of them is a really good practice to have.
The more information, the better. So if you can adjust it in that area as well, it's just another source that the document is kept accurate. So our next question is, when you are charting on a computer and you have a dental hygiene code number, do you still have to put your name at the end of the entry? Again, more is best. It's best to make sure that you are initialing each of your entries. I mean, yes, if you do have a code that is identifying you, but it is just one of those, again, additional precautions just to make sure your initials are there in case it isn't obvious that whoever wrote that and their specific code. So.
Yeah. And it depends on what's happening in the office, and as long as there is a unique password for each operator and staff member, and that only you can log in using that number, and the numbers are somewhere that they can be tracked back to your initial, that would be appropriate as well.
Our next question, can the CDHBC provide us with a template to use in our offices? Feel free to send something by us. We'd be happy to look it over, but each individual practice is so different, and the way the chart is, how each practice does document, whether it's electronic or not. Please send an email our way, and we'd be happy to review it.
Yeah.
All right, next question. Does the CDHBC recommend blood pressure being taken at every appointment?
So taking baseline vitals is a practice standard with the college. However, you do have to use your professional judgment on this. There are clients who are at a greater risk for a medical complication, or there may be times that they're on a new medication, and it is important to take the baseline reading for that, and then at subsequent appointments, based on the rest of the medical information that you've obtained, that is when you would update it. And it is important to be taking blood pressure prior to administering local anesthetic, as you are incorporating a drug into that person, and you want to make sure that you are preventing any medical complications or emergencies.
Excellent. So our next question, after completing your dental hygiene care and you're in the maintenance phase, do you still need to document informed consent for every recall entry? So this is a very good question, and yes, you do, because it's that individual appointment that you will be presenting the information and analyzing that assessment data, and you'll be updating that dental hygiene diagnosis, and the client does need to then give informed consent once they understand the risks and benefits and all that, moving on.
Yes. Yep.
Excellent. All right, bear with us as we scroll through here. Great questions, everyone. All right. How would you get the patient to initial treatment if you're using electronic records? Very good question. Yeah. I'll let Jackie take this.
Good question with that. In a situation like that, there's a couple of options. Some offices are using just a tablet, and they're getting the client to initial on the tablet, and that goes into the record in the chart. Other offices are having clients initial on a hard copy, and this gets scanned into the client's folder and housed in a specific section of the chart. However, to document their informed consent to care, it still is appropriate for the dental hygienist to document that verbal informed consent was obtained, as that still meets the practice standard for informed consent. So there's several options. If you do have concerns about that or further questions, please give us a call, and we can let you know if what you're doing in your practice is meeting the practice standards.
Excellent. So next question, does it fulfill the probing documentation requirement by writing that probe readings are less than or equal to 4 millimeters? Sorry, let me just comprehend this. So just by writing, okay, are less than or equal to 4. No, or well, first of all, I should clarify. Baseline periodontal assessment data needs to be done. So that includes full mouth probing, because you need to have that initial picture in order to properly analyze that information to come up with a dental hygiene diagnosis, and that includes probing for the full mouth. In regards to updating, it really is up to the individual's professional judgment and that client's specific condition in regards to how that is updated.
Yes. Yeah.
All right.
So if there are no changes in those probing depths, it is appropriate to say probing completed, no changes, or you could write down where the specific changes have been made without writing them all down. However, there needs to be some documentation in the chart stating that that update took place.
Excellent. Moving on. If the dentist does the recall in your room, who should initial the dental findings / diagnosis / treatment, the dentist or the dental hygienist?
That's a great question, and the answer to that is more of a collaborative approach. When the dentist is talking about their findings that they found related to specific findings that are within the dental scope of practice, but he is saying them or she is saying them to you, you can be documenting those down, and the dentist diagnosed caries on this tooth or an endo lesion. You can document that down, and you can still initial that entry, or depending on the protocol in your office, at the end of the day, you can still have the dentist initial that portion, but when you're documenting that the dentist made this diagnosis during their dental exam, that is saying that they were the ones who made the diagnosis. So either way is acceptable.
Excellent. So our next question is, what is acceptable for documentation of informed consent? Can you give us an example? So this is something I talked about earlier. It needs to be documented that informed consent was obtained. So you need to discuss with the client what your dental hygiene diagnosis was, your findings during the assessment phase, what the care plan is, and they need to be aware of all the risks and benefits associated with that. And if once they have given their consent, you just need to document that informed consent was obtained from the client. So this was one of the kind of practical applications I talked about. You can include on a template chart form, a little tick box saying informed consent obtained from patient, and you can tick that indicating that that is what you have done. So then if your chart was ever reviewed, someone looking through can say, okay, the client was informed of, all of their risks, benefits, treatment options, etc., and that informed consent was obtained from that patient. And sometimes, if you want to have the client initial as well, that again is just going above and beyond if you wish to kind of ascertain that. But that's kind of that basics, that entry is made, and that of course that you have initialed it.
Yeah. And it might also be worth noting that you could document down that verbal informed consent was obtained, as this way when you're providing your initial, you're saying that that verbal consent was obtained from the client. Otherwise, informed consent was obtained for the dental hygiene care plan, and then the client can initial that. Mm-hmm. So either one is acceptable.
All right, for how long do you continue to document the same perio status if there's no improvement or change? Indefinitely.
Good question. As the periodontal documentation and assessment is really a key component in developing part of the dental hygiene diagnosis, it is important that it is assessed at each appointment. However, if there are no changes, and you confirm that with the previous readings, you can say probing has been completed, no changes from the entry on this date. However, if you are getting a few years out and you keep writing that down, there may have been some changes. There may have been some more inflammation or bleeding in an area. So you want to make sure that you're still showing the full picture of the periodontal health.
Great. Next question. If the probe depths, furcations, recession, etc. is documented on the perio chart, do we have to include these number ranges in our notes section as well? So no, if you do have a different area of the chart where you have all of your, periodontal assessment data, I'm thinking a periodontogram where you have all that documented and it's part of the client's chart, that is great. That's still part of the client's chart and you don't need to repeat that information somewhere else.
Yeah.
As long as it's included in there somewhere.
It is worth mentioning that it would be appropriate to write down in the official, dental hygiene notes section of the chart that periodontal assessment was complete. And then it is known that you would have to go somewhere else in the chart to find that full documentation of all the elements you were saying.
Mm-hmm. Yeah, but you don't need to transcribe the full numbers of it all. What is the college's thoughts on adding personal information into documentation entries, such as the client went to France this summer or they're getting married in 2015?
So good question. Mm-hmm. And when you're seeing a lot of clients in a busy practice, sometimes having those notes for yourself does help jog your memory about, oh yeah, I remember there was that deep pocket on the distal of the 1/6. However, you do need to remember that the chart is a legal document and clients do have the ability to ask to see those charts. And so it would be more appropriate to keep those notes on a sticky as opposed to including them in the legal documentation or the treatment notes section of the chart.
Excellent. Regarding time to keep charts, if you are independent and close your business, does the 16 plus 1 year rule still apply?
Really good question. And yes, it still applies. So when you are an owner of an independent practice, you are responsible for still maintaining the Limitations Act and keeping the charts for 16 plus 1 year or 15 plus 1 year, which is 16, or for child clients up to the age of 19, it needs to be then 16 years past that. So if you're closing your practice, you are responsible for finding a way to securely store those charts in a confidential and secure manner. And this may be with a third party that houses them, as long as you know that it is secure. And then at the end of that time, they can be destroyed in an appropriate manner. So that is a really good question. Thank you.
All right. We have about 10 minutes left, so moving on. Once in maintenance phase, do we have to document future dental hygiene treatment planned for the next recall? For example, next appointment, 3-unit scaling, etc. So yes, that is part of the planning phase of the ADPI process of care, and making notations. What this looks like is up to that individual practitioner, but it is important to make some planning notes for the next phase of care. And of course, if you are sharing, if it's an office where there's multiple hygienists, that does help. You can see what the previous dental hygienist had written and thought was planned for the next appointment, but it does just keep your documentation records accurate.
Yeah. And I might just add to that as well, and I think I'm understanding this correct. If you're writing follow-up information, it really only has to apply to the evaluation that you want to complete. So writing down that 3 units of scaling needs to be completed in 3 months or 6 months may not be realistic, as at that next set of continuing care appointments, you'll be going through the assessment phase again, and maybe at that appointment the client has had fabulous home care and their gingival condition has improved, and so they only need 2 units of scaling. So you don't want to plan for interventions like that. However, you may have wanted to follow up on an intraoral lesion that might require referral. So definitely keep those things in that. So your follow-up really is more based on evaluation and those outcomes of the goals.
Perhaps instead of saying, for example, 3 units of scaling, you can say 45 minutes, because then that, I know we need to sometimes plan for the next appointment and how much time you need, but kind of keeping it in those terms then allow for what Jackie was saying, for that next practitioner to determine the actual care that needs to be provided.
Okay.
All right, I've seen on charts in the past that other hygienists wrote no pockets less than 4 millimeters. Generally 4 millimeters, generally, not sure what that says. Is this enough information, or shouldn't they note all probe depths? Sorry.
I'm just reading this one more time.
So I think it's just saying, like, they're not writing, I'm going to take this as they're saying they're not writing all probe depths and simply just saying that no pockets are less than 4 millimeters, or they're all generally 4 millimeters.
Yeah.
And again, this goes back to having that baseline assessment data for the whole mouth, so you can see that full picture and be able to plan treatment accordingly, and then evaluate to see where that baseline data has moved to.
Yes. So basically, that is not enough information. There needs to be baseline probing, and then follow-up could be, no changes in probing depths from, October 20th appointment. Yeah.
All right. Do we need consent to share records with other dental offices, i.e. digital radiographs?
Yes, good question. Because of the Privacy Information Act, you do need permission to share those radiographs. And again, you can just have the client initial that they've consented to those radiographs being sent to, Dr. X or whoever they're going to. Or you can write in the chart that the client gave verbal consent for the x-rays to be sent to that doctor.
All right. Thank you very much for your questions. For patients with dementia living in long-term care, would consent then be given by the family or the guardian? Great question again.
Great question.
Go for it.
You know what? If it has been determined that that client is not able to make informed consent on their own, there usually is a legal guardian or someone in the family who has been given the authority to make that consent for them. So just finding out who that person is, and sometimes it is with the physician who's working with the facility, sometimes it's with a nurse, a lot of times it is a family member. So still document that informed consent was provided by whoever that primary caregiver is for them, if it's their daughter, their son, or if it's the nurse in the facility. Great question.
All right. Are we responsible to document information regarding referrals or etc., which were discussed with the dentist while in the hygiene chair? I think we kind of talked about this earlier that, it depends in the office and what kind of your protocol is. And if that is, being done, feel free to make those notations. But having that, you initial that entry as well because that did happen in your chair.
Yeah, and it is just important that that discussion of the referral is documented. So a lot of times, if the dentist is in a busy practice, they do rely on the dental hygienist a lot to take those notations down in the chart. And so you can just confirm later that I wrote down that you recommended they go for an ortho consult or for an endo consult, whatever it was. And then you can initial that section, or again, depending on your office policy, the dentist may initial that.
All right. Sorry here. If the recall was not completed in my room, is it sufficient to document it that the recall was not completed in my room and then leave it up to the dentist to document their exam? The recall not completed in my room is sufficient to document.
And for this one, yes, it is sufficient that the dentist, or sometimes the dentist will rely on the certified dental assistant to document that. So you do not have to document that in the chair. However, if there is no documentation in the chart that a 365-day exam took place and it just occurred that day in a previous chair with the dentist, you can document that down just to show evidence that that exam did take place.
So how to appropriately document refusal for radiographs, fluoride, polish, etc. Great, so part of informed refusal is making sure the client, again, is aware of those risks and benefits. So you need to document that you have discussed this with the client, that they are aware of those risks and benefits, and then initial that entry in the chart. And it needs to be documented, and in particular, whether it was, bite wing radiographs or fluoride treatment or the polish. And it's important to also update that over time because things change, and it is important every time that client does come in to review that, particular things such as radiographs. But just making sure that they do understand that and that this can just be documented, that the client has been informed of the risks and benefits and they chose to decline this portion of treatment. And that was, again, something I had mentioned about kind of informally having the client initial that entry as well, because that just really confirms what was said.
And I think we have time for one last question here. So I'll let you read the next one off here, Melissa.
Let me just find what is next. What is the most politically correct way to communicate on a chart that a client is very difficult to work with? That is a very good question.
And I think the key to the answer here is in a very diplomatic and politically correct way, as the client does have access. And you know what, it may be in the form of, communication with the client did not appear to be clear, or you can even say, the client was unsure of documenting these, or of accepting treatment and the reason why. But just be very careful with the wording that you use, as it is part of the legal document, and the client has a right to access those documents at any time.
Excellent. So unfortunately it is 8 o'clock already, so I do see we have some other questions coming in. For those we didn't get to, I apologize, but please email us your question and we'd be more than happy to answer, or give us a call as well.
Yes, exactly. We will be sending up a follow-up survey in the next couple of days just to get your feedback on how the presentation went. As with ADPI we were discussing tonight at the college, we also like to evaluate what we're doing as well through our own almost like evaluation process. So we'd appreciate you answering that when it comes out. So stay tuned to your emails for that. And again, we would like to thank all of you for taking times out of your busy life and busy schedule to join us this evening, and fabulous questions. Thank you very much.
Thank you.